Good afternoon to one and all. So I'll be doing my topic usefulness of the diabetes remission scores. So what is the need for a prediction? Basically, accurate prognostic assessment may safeguard against putting patients in a high risk situation. For example, if we can predict that such a patient will remit diabetes if he undergoes this particular surgery, then it would be a good thing to tell the patient what are his chances of remission once he undergoes surgery. So this allows us to take informed treatment decisions for both patients and physicians in this case, and especially when considering surgery to treat type 2 diabetes. This could, in a way, prevent unnecessary economic burden on the healthcare systems. What are the features of a proper prognostic model which can predict the outcomes? So they should be mainly accurate and generalizable. Also, internal and external validations are necessary to confirm such models. And there is something called calibration and discrimination, which are the major evaluation methods for prediction models. We'll learn a bit about calibration now and discrimination also. So calibration, it refers to the agreement between the observed and the predicted outcomes. It can be assessed either graphically by plotting or statistically. By statistics, we would use either it is called the goodness of fit test, and there are many such tests, and one of the examples would be the Hosmer-Lemeshow test. Coming to discrimination, it refers to the ability to discriminate individuals with the outcome and from those without the outcome. So the statistics used for this would be the C statistics, the concordance statistics, or more commonly the area under the receiver operating characteristic curve. So this is the area under the ROC. This is a graph basically plotted against like the true positive rate versus the false positive rate. That is sensitivity in the y-axis and 1 minus specificity in the x-axis. In this case, what we see is the graph can be either perfect, like the one in the violet line, where a threshold is perfectly classifying the cohort into two proper classifications, and if the classifier is not so perfect, then we'll have graphs which are shown here. So for example, the blue line, the orange, and the green line. In this case, again, the better model would be the one having the more area under the curve obtained. So the area, if it is higher, then the discriminatory ability of the model would be much better. So while plotting this graph, the many thresholds are used so that when you plot the true positive rate versus the false positive rate with various thresholds, this kind of a graph would be obtained. So with that basic knowledge, let's proceed to the topic proper. What are the scores which are available for predicting diabetes remission? There are many scores. So the few famous scores would be the ABCD score, the DIREM score, the Diabetes score, the Advanced DIREM score, the IMS score, and there are many other non-validated scores also. So let's see each of these. The ABCD score includes preoperative variables like BMI, C-peptide levels, type 2 diabetes duration, and age for calculating a score which will predict the outcome. The DIREM uses insulin use, age, glycated hemoglobin levels, and the type of anti-diabetic drugs used. The Diabetes score uses HbA1c, medications used, and the duration of the diabetes. And the Advanced DIREM score is a modification from the DIREM, and it adds the duration of diabetes and also number of anti-diabetics drugs used, and also it modifies the scoring used in the DIREM so that a different score is obtained. And the IMS score uses the HbA1c levels and number of OHA levels and the duration of diabetes and insulin use. So let's go. So before proceeding, it was in 2003 when Shore and colleagues noted that patients with longer preoperative duration of type 2 diabetes and those using insulin which suggested an advanced disease, and also those with a lower weight loss after surgery were least likely to achieve resolution of type 2 diabetes after Roux-en-Y gastric bypass. But at that time, there were no published prediction models which were available. So this was in 2013 when the ABCD score was developed. Lee et al. Had an Asian cohort of 63 patients who underwent Roux-en-Y gastric bypass, and they used multiple regression analysis to include 4 variables into a scoring system which they developed, and they called it the diabetic surgery score, but finally it came to be called as the ABCD score, because it included 4 variables which started with A for age, B for the body mass index, C for C-peptide level, and the duration of diabetes. This was also validated in a prospectively collected cohort of 176 patients. So according to the ABCD score, which they called it as the diabetic surgery score, so we see here the scores range from 0 to 3 for each of the 4 variables except the age, where there were only a score of 0 and 1. So a higher score was given if the variable had a better chance of remission. For example, in BMI, the higher the BMI, it was predicted that the remission would be higher. The chances of remission would be higher. When it came to the duration of diabetes, if the duration was lesser, then the chances of remission was higher. So that was given a higher score in this model. So when we total the scores, it ranged from 0 to 10, and with 10 having the highest chance of remission. In their model, it was 100%, and if it was 0, the remission rate would be 33%. Next, let's see the diagram score. So it was in 2014 that Christopher Still and colleagues developed a novel scoring system called the diagram score to predict the remission of type 2 diabetes after Roux-en-Y gastric bypass. So in their publication, the diagram score it was based on a cohort of 690 patients, and it was a retrospective cohort. All of them had diabetes, and they had a minimum follow-up of around less than or equal to 2 years, and all of them underwent Roux-en-Y gastric bypass. They used the Cox regression model to develop 4 preoperative variables which were identified for the final scoring model. These were the insulin use, the age, the glycated hemoglobin, and the type of antidiabetic drug used. So on the basis of the final score obtained, the patients were divided into 5 groups, which we'll see now. So these were the variables which were used and the corresponding scores. For example, the age, if it was lesser than, in this case, they gave a higher score in case of a lesser probability of remission. So if the age was higher, they gave it a higher score. Similarly, if the glycated hemoglobin level was higher, the score was higher. And also here they differentiated between metformin and other OHAs. For example, the sulfonylurea group and the other insulin sensitizing agents. So if it was only metformin, then score was 0. Score of 0 was given. Any other OHA, the score was 3. And the highest weightage was given to insulin with a score of 10 if there was insulin use in the patient. So accordingly, they classified the patients into 5 groups, with the lowest score group of 0 to 2 in their cohort achieved a remission, partial or complete remission of 88%, and a complete remission was seen in 61% patients who underwent RYGB. If it was the highest score, 18 to 22, the remission would come down to around 2% and 0%. And the confirmation cohort done in the Cleveland Clinic was almost comparable. So for example, here it was 86 and 55%, but in the higher score range, we can see it was not so much comparable. So we'll come to that in the next few slides. So this study by Wood et al. Tested the performance of diagram score on Hispanic and non-Hispanic groups, and also various procedures, various other procedures like sleeve and the LAGB. So they found that in this case there were 361 white and 130 Hispanic patients, and 340 of them underwent RYGB, 119 underwent sleeve, and 61 of them underwent LAGB. The discriminantability of the diagram was moderate to high in all types of surgery, but it was found that the diagram performed much better in RYGB and LAGB group compared to the sleeve group. And also it was found it had a good discriminant ability in both white and Hispanic patients. Let's go to the IMS score first now. So it's the Individualized Metabolic Surgery Score. It was done by Aminian et al., and it was based on a cohort in the USA. 659 patients were included. They had a 5-year follow-up, and it was finally validated with Spanish cohort of around 241 patients. A total cohort would amount to around 900. So this was the largest cohort for such a predictive model. They basically constructed a nomogram with 4 independent predictors for the long-term remission. So this was the nomogram which they constructed. This shows the points. So it varied from 0 to 100. And the 4 variables which they used were the number of diabetes medications, the use of insulin, then the pre-op duration of the diabetes, and also the glycemic control. Here it was either glycated hemoglobin of less than 7% or more. So accordingly the scores were given. For example, if there was insulin use, the score would be a score of around 18 would be given. And if there was a glycemic control, if it was less than, if HbA1c was less than 7%, then the score would be 0. So finally a final score would be given, which would add up. And according to the final score, the groups were classified into mild, moderate, or severe. And they also went ahead and recommended procedure which would be better for such patients. So for example, the mild group, they recommended that RYGB was better, was suggested even though both procedures, sleeve and one more thing, the cohort included both sleeve and the RYGB patients. So finally they suggested that in case of mild group, then RYGB is a good choice, even though both procedures were equally effective. In case of the moderate, sleeve was found to be less effective, so they recommended RYGB. And in case of the severe group, sleeve gastrectomy was suggested, even though both procedures were less effective. That was in order to reduce the risk for the patient, basically. So in their results, the groups were divided into mild, moderate, and severe. And the remission rates which they achieved was like 92% in case of RYGB for the mild group. It was 60% for the moderate, and severe group had 12% remission in case of RYGB. And in case of sleeve, it was a bit lesser. So mild had 74% remission, moderate had 25%, and severe had 12%. And this was compared with the validation cohort as follows. It was almost comparable. So next, there was the AD-DIREM score. This was again a modification to improve the DIREM score for prediction of the remission of diabetes at 1 year post Roux-en-Y gastric bypass. So the advanced DIREM score added 2 more clinical variables: the diabetes duration and number of glucose lowering agents. So they also modified the scoring for each category to improve the predictive performance. And AD-DIREM was found to have better accuracy than the DIREM. That was especially true when there was the extremes of score, like the lower score of 0 to 2 and the 18 to 22 range of the DIREM scores. So this was the AD-DIREM score, in which they used age, HbA1c, insulin. So in this case, insulin was given only 3 rather than the 10 which was given in DIREM. Also, they added duration, and also the number of glucose lowering agents were used. So according to them, they evaluated the DIREM and AD-DIREM performance for the whole cohort. In this case, the area under the receiver operating characteristic curve was plotted. We see here that the AD-DIREM is represented in the 2 cohorts with solid lines, and the diagram score is represented with the dotted lines in the two cohorts. So red is one cohort and the blue is the second cohort. It was found in both that the AD diagram had a higher area under the receiver operating characteristic curve and also a higher accuracy. They specifically evaluated the discriminatory capacity of diagram and AD diagram in lower and the higher score ranges. So again, it was found the AD diagram, which was represented by the solid lines here, was much more better compared to the diagram, especially at these extremes of scores. So again, the area of under the curve was much higher in case of the AD diagram test. They also compared the diagram and AD diagram for the mid-range scores. So in case of the mid-range scores, it was found it was that there was not much of a difference. So they equally performed in case of the mid-range scores. There is something called the 5-year AD diagram score also. So in this case, it includes a 1-year follow-up data or parameters to predict the 5-year outcome later. So in that case, glycemia, number of anti-diabetic treatments, remission status, and first-year weight loss also are included into the final predictive model. And it was found the 5-year advanced diagram was accurate. The area under the curve was 90% and accuracy 85% when compared with the diagram and the AD diagram in predicting the remission at 5 years. So it also correctly reclassified the 13 patients of the 39 patients who were misclassified with diagram. So this was the area under the ROC plot. So it is clearly seen that the violet graph representing the 5-year AD diagram is having a higher area under the curve, which shows that it had a better discriminatory capacity. And also it is seen the accuracy and the area under curve is much higher numerically also. So comparing all these scores, there were various studies which we'll go through one by one. So 4 prediction models were compared in this study in China. The ABCD score, the diagram score, and the advanced diagram and the diabetter scores were compared. They found that the diabetter score model exhibited the best predictive performance. And it was followed by the AD diagram score, which had the second highest discriminatory power after the diabetter model. And also they found it to be having an excellent calibration. So this was the 1-year follow-up predictions according to the this study. So in this they found they evaluated all the 4 models, and they found when it came to discrimination, the area under curve was highest for the diabetter score, followed by the diagram, followed by the advanced diagram, and also when they evaluated the calibration using the Hosmer-Lemaitre test, it was found the p-value was least for the AD diagram. So calibration was the best in case of AD diagram for the 1-year follow-up cohort. And also we can see the actual diabetes remission rates, and the predicted to observed ratios are quite comparable in case of all these 3 scores. But when it comes to statistics, the best discriminatory capacity was in the diabetter, and AD diagram had the best calibration. When they applied these models to the 3-year follow-up, we see that the area under curve was highest again for the diabetter score, so having the highest discriminatory capacity, and also the calibration was with a p-value of 0.058. The diabetter score again had the best calibration for the 3-year follow-up. Now when we see the predicted observed ratios, so it is close, very close in case of the diabetter score. Diagram score also is close, but the discriminatory and calibrative capacities were not that high according to their study. So this was the area under the receiver operative characteristic curves, which was plotted. So the solid line representing the diabetter score has the highest discriminative capacity, followed by the dotted line, which is the advanced diagram score, followed by this, which is representing the representing the ABCD score, and the least area under the curve was in case of the diagram score, according to their study. Next study was in a Mexican population by Gonzalez et al. However, they had a cohort of only 63 patients with more than 1 year follow-up, and all of them underwent Roux-en-Y gastric bypass for the diabetes. So at 12 months, complete remission was obtained in case of 79.4% in their cohort, and the ROC curves were plotted. But in their case, diagram score had a sensitivity of 81% and specificity of 80%, with area under curve being 0.773. While the ad diagram had a sensitivity of 83% and specificity of 70%, with area under curve being higher than diagram score at 0.792. While the ABCD score and the diabetes score did not have a high AUC. So according to their study, the advanced diagram score performed much better. So this was their area under the ROC plot. The orange line showing the diagram score and the blue line showing the advanced diagram score. So advanced diagram score had the highest area of under the curve with highest discriminative capacity. They did not test for calibration, however. This study by Pussy et al. It had a Caucasian cohort in this case, and they underwent both the Roux-en-Y gastric bypass and sleeve gastrectomy procedures. And here they compared the diabetes score and the diagram scores. So according to them, they had comparable predictive values. Also, they found that weight loss plays a major role in improvements after metabolic bariatric procedures. So this was the area under the ROC curve. So comparing diagram and diabetes, we see that both the graphs are almost same. So, but numerically the area was a bit higher for the diabetes. Both had equal capacities, according to this. This study was by Tarakan et al. From a UK population. So here they evaluated diagram score in predicting the remission in a ethnically diverse population. So it included Caucasians, Asians, blacks, and mixed ethnicities. So they found out that diagram score remains useful in predicting diabetes remission in multiple ethnicities when the diagram score is low. But when the score is higher range, the predictive power is less for diagram score. This was found out by this study. Next study was by Lee et al. They compared the diagram scores and the ABCD scores. So it was a retrospective cohort of 245 patients who underwent the gastric bypass with a 1 year of follow-up, and all had type 2 diabetes. The ABCD, they found that the ABCD score is better at predicting the remission at 1 year after a gastric bypass when compared with diagram score. So next came this study by Chen et al. Here they compared the IMS score, Individualized Metabolic Surgery score, and the ABCD score. 310 patients who underwent gastric bypass and sleeve gastrectomy from Taiwan had, and also all these had a 5-year follow-up period. So when they evaluated the two scores, ABCD was found, score was found to be better at predicting remission compared with IMS score. So this was the comparison they brought out. So the IMS score here for sleeve group and the gastric bypass group. So when the according to the IMS, the groups are classified into mild, moderate, and severe. So for the mild, in this cohort, they found the remission rate was 86%. And according to the original paper of the IMS, we know that the prediction, their cohort showed a remission of 74% in the original, and the confirmatory cohort of 91% in case of sleeve. So this was the comparison made in this cohort. And in case of severe group, it was found the remission was 0%. However, in the original model, they had predicted 12% in the original, and the confirmation cohort had shown to be 3% in case of sleep. When it came to gastric bypass, however, the remission seen in this present cohort was the 96%, and what they told in the original cohort for the mild group was 92% and 91%, so it was almost comparable. And in case in case of the severe group, here there was 17% remission seen, and they had predicted 12 to 8%, so it was almost comparable. When it came to the ABCD score, in case of sleeve gastrectomy, what we know, in case of ABCD score, the ones with 10, 9, 8 had 100% remission according to the original paper, and those with 0 or 2 had around 30 to 40% remission. So when we see that in this study for sleeve patient, the remission was 86% in the highest score group, and in case of 0 score group, it was 0%. However, in the gastric bypass, we see that the remission was 98%, almost close to 100 in case of highest score of 10 to 9, and in case of the lower scores of 0 to 2, it was 18%. So finally, they concluded that ABCD score was much a bit better at predicting the remission. So to summarize and conclude, a few important points would be: each score has its own advantage and is fairly accurate in predicting the remission of diabetes. For any score, inadequate discrimination and reduced calibration can occur when we apply it to a new setting, which is different from the setting in which it was developed. For example, if we apply a score which was developed using a RYGB cohort for a sleeve cohort, there may be reduced accuracy of prediction. These scores are helpful for taking informed decisions, both for the patient and the physician. There may not be one best score. One thing is that how the physician himself expresses information to the patient also contributes significantly in the decision making, and it cannot just be based on a score itself. So this would be the concluding point, I would say. And the updating of score with new developments, for example, the 5-year ad diagram incorporates the 1-year results, 1-year variables also. So this increases the accuracy of prediction in scoring models. So if the scoring model can include the that, then it will be much more accurate. So with this, I'll conclude my seminar. Thank you.
Thank you, Prasanna, for an overview of the course. Very well presented. Only thing is, I would still like 2 questions. One is,
Yes.
what are the drawbacks of ABCD score if they have given in any of the papers?
Yes,
And 2, the various scores were not only like procedure specific like variations,
yes.
but also ethnicity. So do you think they've been able to solve that problem of ethnicity? Are these scores like advanced diagram applicable in all the ethnic settings? Although I know you have quoted a study from London, UK,
Yes.
where a multi-ethnic population was taken. So, but have they been able to show the same degree of prediction in a Caucasian model versus an Asian model?
No, sir, because for example, diagram score with a higher score range, it's shown to have a lower predictivity. So that is already mentioned in that study. So it should be for each ethnicity, they must, or they should keep a cohort which includes all the ethnicities. Otherwise, the prediction might be altered, and that is the issue.
So that's exactly I'm asking you. Have they been able to? Are there papers of diagram in Caucasian population, papers of diagram in Asian population, and then they're showing similar remission of diabetes?
I couldn't find such a paper, sir. And in Asian population, it's not, especially for coming to Indian population, I didn't find any study at all. But in Chinese, they compare the scores. However, they don't test only the diagram. So these were the papers which I could find. But in Indian population, I did not find any.
So what do you think is the utility of? I know you quote again said about utility of this course.
Yes,
so when we have only 2 procedures, so let's say 3.
Yes.
We know bypass procedures versus let's say sleeve. So we can combine RYGB and OAGB versus sleeve. So broadly, we have only 2 procedures. So it's basically to say, okay, we want to offer sleeve or bypass. That it comes to that.
Yes, sir.
For any prediction. So we want to say mild form of diabetes. We generally, that was the principle we followed. whether it's a score or not, just by rule of the thumb, it's a milder form of diabetes, you give sleeve, and a severe form, you give a bypass. But you quoted one paper where the more severe forms,
yes,
because the remission rates were same, low, and same with both, you said sleeve is a better procedure because of the less complications.
Yes.
Yeah.
So, sir, it would
do you think that is well accepted? That's a well accepted argument.
Yes, sir. One thing is, like, in case of this severe group in the IMS model, so if a sleeve is performed, there is always scope for the revision. So that might be one idea of that, because risking the patient here and not achieving remission might be bad, because his preoperative parameters would have improved after sleeve. So that might increase the chance of remission in the second procedure. That's what I inferred from this.
Okay.
Time.
Okay.
Maybe that is the way. But I think there is a lot of studies which should be done from, again, our population and Asian population, so that the whole ethnicity is involved in this.
Right. Okay. Good. Any other comments? Nobody wants to ask a question?
Hello. Hi, Prasanna. Hello, Prasanna.
Yes, sir. Hello.
Nice presentation. Just I want to ask, do you find any study who is comparing RYGB versus MGB on the remission of diabetes?
No, sir. That's
different.
MGB, I could
not find any.
I will. In all these papers I referred, I couldn't find one which included the MGB code. I can search further. See, sir, if I can find, I will post it.
Okay. Second question is, what are the advantages of advanced diagram, 5-year advanced diagram score? Because at 5-year follow-up, many patients come with the weight regain, and I am not getting how this score is really going to predict further remission after 5 years.
Yes, sir. This side. So in this case, the 5-year diagram includes the 1-year follow-up data. So by 1 year, we could know that how the patient is adhering to, say, the diet or anything, and the glycemic index, how it has improved over 1 year, is incorporated in the for the 5-year prediction. So I think that increases its accuracy in prediction for the 5 years. So that is what the advantage is of the 5-year ad diagram when compared to the simple plain ad diagram.
Right. Hello, good. I think that's a good presentation, and I think we have also analyzed our data. Mehul did it, that MBBS student, and I think it's going to be published in JMAS soon. It was accepted as a paper. The only issue was we had less numbers in the OAGB group, but also these scores are not, meant for Asian population as so there was some credit, so we could not get it published in OB. I think we sent it to a better journal initially, but there were a lot of objections about validity of these scores in Asian population. So ultimately it did not get it. So, but it's getting published in JMS. So we have some data. So according to that paper, advanced diagram is probably the best predictive model.
Yes.
Good, short and sweet, and that's what we want. Should be able to finish in 40 minutes, including discussion. Chalo, thank you.
Thank you, sir.
Thanks. Take care. Bye bye. I'll post the next list of presentations. I think Monday, Friday. We'll have Monday, Friday.
Yes.
Okay. And I'll post the next list soon. Okay.
Sure.
Thank you. Bye.
Thank you, sir.
Bye.
Thank you, sir.